least we got everybody's attention. Welcome back. You've got to watch out for the sharks that are in the water. We've got a whole bunch of excitement coming on today. This Shark Tank experience is what we've really been looking forward to. This is the chance for all of the innovators out there to come in and talk to us, show us what they've been doing, a little competition. I'm sure you've seen this across the ages. Shark Tank becomes an exciting event. So I am here with Blake Henderson, a longtime employee at the VA, someone that I've gotten to know since our time in New Orleans last year, where you were down running the experience in New Orleans, our hometown, for Dr. Ryan Vega, myself, and Fernando Rivera, and actually the secretary has a connection. So wonderful to have you here to tell us all about Shark Tank.
Thanks. It was fantastic seeing you back in February in New Orleans. It seems like a lifetime ago. This suit fits a little snugger than it did back in February.
Yeah, you know, they say that the dryer is not the culprit. It's your pajamas and pajama tops and sweatpants that lie to you. It's not the dryer.
It might have been hanging out in my basement for the last 7 months that had
But no COVID beard. Nothing going on there.
No, never rocked the COVID beard. Didn't go there.
So tell me, you've got this all put together here. We've got Shark Tank. What have you been doing over this COVID experience? You're not hanging in your basement. What else you got? Anything new going on in your world?
Well, as you remember back in February, we were actually bringing all the teams from last year's Shark Tank together to create their plans to replicate their practices in other facilities. We did that in February, left there with very strong plans, and then less than a month later, the world had completely changed.
Right.
And so it was really neat to see this last group, how resilient and adaptable they were. A lot of those practices went on hiatus for 30 to 90 days, but really everybody came back online without fail and started confronting the problems of the day. Many of them adapted and changed their practices, incorporating a lot more virtual modalities. So it was a real great thing to see, actually.
Did you find that people were a little more creative because they had more time? Did you find that they were finding different experiences that made them think twice about how they were doing their business in day-to-day VA? Did that prompt a little bit of this?
Absolutely. I think like a lot of things post-COVID, it made people think, well, why can't I do this virtually, especially, whether it was training clinicians or working with groups of veterans. We have one practice that was doing in-person group visits with veterans for mental health issues and opioid abuse, actually, and they converted to a fully group model virtually online with Zoom meetings.
Really?
And they're getting great engagement. So it's like a whole new world opened up for them.
Yeah, I would say so. But you know, you've been doing this for a long time. So tell us, how does Shark Tank work? What can we expect for this afternoon?
Sure. So first of all, the 2020 Shark Tank competition began more than 4 months ago when VHA employees and teams from across our healthcare system submitted more than 400 promising practices to the competition. Since then, we enlisted over 100 VHA leaders to evaluate and score the submissions, bringing us to the 15 finalists today.
That's an exceptional process. That takes a lot of time. So 100 leaders read all these proposals.
Absolutely.
And everything from minor to major transitions, I would imagine.
These are leaders who volunteer their time to look at these proposals. Most of the proposals got at least 5 reviews. So we took the process very seriously. The submitters who submitted their practice take this seriously, and so we try to reciprocate.
So for the folks that didn't get a head start on this and they were kind of snoozing in their basement, maybe taking a little more time, how would they get involved in Shark Tank? Maybe not this time, but in the next time, how can they dive into this?
Sure. Well, we're actually going to rely on our audience today to help us pick one of the 10 Shark Tank winners. Every attendee can cast a vote for their favorite practice.
So this is like American Idol here. You're going to be able to vote, or The Voice, you vote for your person, huh?
We want to hear from our community, and we want to hear from the people. You know, what inspires you the most? So under the polling menu option of the event app, you can cast your one vote. The popular vote winner will automatically be one of our 10 Shark Tank winners announced tomorrow.
Well, that's fantastic. So this is your chance. If you want to take a look at you see an innovation that makes your heart beat or you think it's really great, you can bring that forward. And you know, what should we see in the actual application of it today? What's the tactical? How does this look?
Sure, let me walk you through that. So first, each of our finalists will have a 3-minute pitch. They will use that time to highlight the practice's impact, as well as what it takes to successfully replicate their practice. Each pitch will be followed by a 2-minute question and answer session with our Q&A moderator, Devin Harrison, who's joining us off-site. At the same time, we have 38 VISN and Medical Center Sharks joining us online. These are folks who manage healthcare systems that cover tens of thousands, if not hundreds of thousands of veterans. And they take their work very seriously. They know the solutions that they need to address the problems of the veterans they serve. They also know the tools that their employees need. So it's exciting to have so many leaders online with us right now. And they're going to be bidding actual resources to bring these practices to their facility.
So they're putting money where their mouth is on this one.
They're making firm resource commitments of either funding and as well as FTE that they're willing to invest to bring the practice to their facility.
And by the way, I hear there's some great news from your family that's exciting coming out of this whole pandemic, right?
Yeah, I appreciate you going there. Actually, my wife and I are expecting our second baby girl in March. So maybe there are some really good things coming out of this.
Yeah, I was going to say, maybe you found a few other things to innovate during the COVID experience here. Hey, you know, I've been looking for my buddy, the shark. He has been jumping into every single meeting that we've had here. He came in, he did the exercise thing with me. I don't know where he is, Blake, but you know, he's been pretty consistent.
It's kind of hard. It's kind of hard to miss.
It's kind of hard to miss that blue guy running around. So, you know, where's a shark when you need it? There's never a shark around when you need one, but always one when you don't. So I'm not.
I got it from here, Joe. Don't worry about it.
You think you can handle it?
Absolutely.
I'm going to go look and see if I can find a shark. If you can find another one, that would be great.
You bet.
All right, Blake, over to you, sir.
Well, I think everyone can appreciate our finalists have worked very hard on their pitches, and they're about to put their passion and their work on the line. We have a special person online with us today to deliver a few words of encouragement to our presenters. Mark, are you with us?
Hey everybody, this is Mark Cuban. I just want to say congratulations on being one of the VHA Shark Tank finalists. Each and every one of you has amazing ideas and an amazing business opportunity in front of you in a way that can not only make the VHA better and more efficient and better serving for our amazing veterans, but also possibly change the world in ways we've never expected before. So congratulations. Congrats on being amazing entrepreneurs. This is your chance. Go for it and good luck.
Thanks, Mark. With those words of encouragement, let's go ahead and jump into the Shark Tank. All right, first up, we have Acute Recovery Center program presented by Peter Chin. How are we doing? I can't see anything on this.
How are you? For the next few minutes.
Peter, can you hear me?
Yes? Yes? Can you hear me? Can you hear me?
Yes, we can hear you, Peter.
Should I start?
Yes, please go ahead and start with your presentation. Thanks for your patience.
How are you? For the next few minutes, notice your own emotions for insight. Use your excitement now to imagine, next slide, its complete opposite, a lack of excitement for anything. Temporarily connect with those you've known in mental health crisis. Sadness, stress, loneliness. You might not want to go on. You may want to feel different, yet not stay in the hospital or wait for an appointment. What help might you choose? Next slide. Veteran-centered help with near immediate access, learning mental health skills in a group community. The Acute Recovery Center, or ARC, combines all the elements on the left in a humanistic outpatient group and individual program designed for mental health crisis. We connect with you before you leave, hear your goals, and offer you to start at the next Monday, Wednesday, Friday morning group. You arrive to a welcoming group of staff and other veterans. We do group psychotherapy and connect practical mental health skills to your situation. We also carefully assess and treat risk with evidence-based suicide-specific strategies, like CBT for suicide prevention. The overall experience is one of connection, hope, and empowerment. Over the last 8 years, we have had consistently good outcomes. Depression and quality of life each improve about 80% of the time. Veterans are almost universally satisfied, and they stay engaged in ARC and their follow-up treatment. Next slide. 3/4 of veterans reduce their suicidality in the 3-week program. Concretely, this means veterans stop intending, planning, or thinking about dying. Veterans are hospitalized 60% less in the year following ARC, and less veterans have needed inpatient hospitalization over time. Next slide. We teach veterans to match actions with values, and our ideal bid starts with a values match, a medical center who believes in risk-smart, veteran-centered care and skill building at the point of crisis, a center willing to shift time for efficient crisis clinical encounter. At that moment of suicidality, instead of taking away freedom, ARC empowers choice, using a tool for better decisions, which we can use together. Notice how you feel right now. Assess, do you value mental health recovery and see its role in suicide prevention? Choose. You make the choice whether to place a bid for ARC. Next slide. Try to identify with the veteran experience of being supported in group, of saying things you've been afraid to, of discovering skills to handle intense emotions, steadily allowing you to engage back in your life. Crisis can sometimes be a teachable moment for change. These quotes give a flavor of what I've witnessed, a meaningful impact on so many, including myself. Thank you.
Peter, how you doing? This is Devin Harrison. Can you
Hi,
hear me?
Devin.
Hey, how are you today?
Good.
Great presentation. I appreciate you doing what you do and what you're doing for the veteran. A couple
Thanks.
of questions I wanted to talk to you about, though. You really did talk about the veteran experience, and one of the things you talked about was thinking about dying actions with values. Is it a possibility that you can describe more about the practice from the veteran's perspective and more about what their experience would be?
Well, you know, the primary outcome for me is the veteran experience.
Mhm.
So if I could just, you know, what I want to communicate the most is what it feels like.
Mhm.
And I can tell you that every moment it feels like the right work. And I know for 8 years, almost 1,000 veterans, we've been giving veterans a chance at a time when a part of them really wants that and a part of them might not want it at all. But the vast majority really engage, learn, and apply the ideas to their lives and are better off. So, and a portion of veterans really thrive in ARC. The experience can be transformative for them. And why is that? Well, what I tried to do was give a little flavor of the veteran experience and the way that I structured my talk. There are some similarities in the presentation and the way that we run group. So ideas of balancing thoughts and emotion, values-based choices, having moments of mindful awareness of your inner experience. If you got a glimpse of that in the presentation, multiply that by the 120 minutes and 3 times a week for 3 weeks that veterans get. And that's why it can be transformative for them.
Awesome. And one more question that I want to ask you is, personally, from your perspective, what does this practice mean to you, and why is it so personal to you and so meaningful?
Well, it's so personal because, you know, it's not necessarily people's instinct to, at that moment of suicidality,
Mhm.
give people choice, think about mental health recovery. And our experience and that of our replication in Milwaukee is that it works. The cost is not a lot just because you're shifting FTE. So there's little risk and a lot of benefit.
Awesome. Thank you, Peter. An excellent job.
Thank you.
I'm good. Hey team, thanks for bearing with us as we deal with some audio issues and start to work out the process here. Peter, great job with your pitch. Devin, your questions are coming in beautifully. If you could try to talk a little bit louder, Devin, or raise your volume, that might help some of our listeners hear that loud and clear. We're going to move on to our second pitch. Next up, we have beta-lactam allergy assessments, saving lives one assessment at a time, presented by Amanda Gillian of Vision 9 Memphis VA Medical Center. Welcome, Amanda.
Thank you so much for that introduction. When I was little, I went to the doctor and I got a penicillin shot. On the way home, my mouth began to swell. So my mother very quickly took me back to the doctor. And from that day forward, I was labeled penicillin allergic. Next slide. Now, penicillins are a type of beta-lactam antibiotic. These are great drugs. They're cheap, and they're often considered the drug of choice for most infections. An internal study showed that about 50% of veterans received less preferred antibiotics based on having that allergy label. Now, you may be thinking, an allergy is an allergy. There's not a lot you can do about that. And that's not exactly true. 10% of the population state that they have a penicillin allergy. However, 90% of the time, it may not be a true allergy, or they may have simply grown out of it. So having this false allergy label and getting non-preferred antibiotics can cause treatment failures and the creation of superbugs. Next slide. Now, those superbugs can have a huge impact on both mortality and healthcare costs. Next slide. So at the Memphis VA, we thought, what can we do about this to try to help decide which patients have real penicillin allergies? So we created the beta-lactam allergy assessment. Any clinical pharmacist can fill out this algorithm. Results are then placed in the chart, and many allergies can be cleared from the assessment alone. Patients with more complex allergies are referred to our penicillin pharmacist-led penicillin allergy skin test clinic. In this clinic, the pharmacist actually places the skin test, reads it, and then depending on the results, can say if the patient is safe to receive penicillin type antibiotics or not. 99% of the patients that we have assessed are able to take some sort of penicillin type or beta-lactam type antibiotic. We have assumed that this is about a cost savings of about $1,200 per assessment, and it improves antimicrobial stewardship. Next slide. So you may be asking yourself, how can we implement this at our hospital? Well, the beta-lactam assessment, you really don't need any additional resources. We can help you train your existing clinical pharmacy staff to fill out the algorithm. For the skin test clinic, you do need about a half FTE for that clinical pharmacy specialist, a physician champion, some clinic space, and you need to pay for the testing supplies, and that's about $155 per test. But remember, I did say that you could have a cost avoidance of about $1,200 for every assessment that you do. So you may not have the resources to implement the clinic right now, and I understand that, but we can still help you implement the beta-lactam assessment, which is very effective as a standalone program. So Sharks, let's get you set up to start saving lives one beta-lactam assessment at a time. Next slide. This is my team. I want to thank y'all for your time, and I'll now take any questions.
Amanda, excellent job. Can you hear me well?
I can hear you. Can you hear me okay?
I can. Thank you very much. So one of the things you talked about was no new resources, but you did say for a portion of your implementation, you did need half FTE. Am I saying that accurately?
You are, yes, Devin, yeah.
All right, so let's talk about sustainment. So can you share a little bit more about the sustainment of implementing at a new facility, and what are some of the things that are required and needed to really truly be able to sustain this and also spread it somewhere else?
Yeah, so I mean, this is really kind of a two-part thing. We mentioned the beta-lactam allergy assessment. It can be standalone. And as I mentioned, really no resources needed because most VAs have clinical pharmacy specialists on staff, and that can be worked into their general workload. So as long as you have pharmacists, you can sustain this forever. For the clinic, it is a little bit more involved, and sustainment may be a little bit more difficult. Some of the barriers there is that you do need a physician champion. So making sure that physician champion stays on staff, that you have someone interested in helping your pharmacist with that, that's an integral part in sustainment for that portion. And we're willing to implement these in kind of any combination, whether it be just the assessment, or maybe you're already doing something similar to this, so you just want the skin test clinic, or maybe you need them both. And we can definitely do that as well.
All right, awesome. And let's talk about what the costs may be for that. Can you talk more about those resource inputs and, the cost for implementing the practice?
Yeah, so the cost for the beta-lactam assessment, as I mentioned, is pretty much nothing. You already have those pharmacists on staff. It does take a little bit of time, but typically those assessments, once you get everybody trained, can be done in about 10 minutes or less. So very low resource yield there. When you're talking about the cost of the clinic, about a half of a FTE for a clinical pharmacy specialist salary. It's ideal if you could hire someone to dedicate that time, but you can also use a pharmacist already on staff. So if you had an ID pharmacist or antimicrobial stewardship pharmacist that could dedicate that time, then that would be something you could do as well. And then, as I mentioned, the cost of the skin test supplies are about $155 a time.
Awesome. Thank you, Amanda.
Yeah, and thank you.
All right, great job, Amanda. And Devin, just so you know, we're hearing you loud and clear now, so thank you for making that adjustment. Next up, I'm proud to introduce Drive-Through Vaccination Clinic, presented by Kelly Cruz of Vision 8, North Florida, South Georgia Veterans Health System. Welcome to the Shark Tank, Kelly.
Thank you. Next slide, please. Picture this. Your veteran does not have an appointment for a couple of months. He or she may be disabled. Maybe they I'm sorry, can you hear me? My screen has went. Okay. I can't see. I'm sorry, I can't see anything. Okay, I can see it now. Sorry, I'm not sure what happened there. Picture this. Your veteran does not have an appointment for 2 months. It is flu season. He or she may be disabled. Maybe they wear oxygen. Maybe he or she is on a lunch break from work, circling the parking lot, just trying to find a parking space just to come in to get a flu vaccine. But wait, they don't have to. They can go to the drive-through vaccination clinic. All they have to do is roll down their window and roll up their sleeve. That's what we did at our facility. It is so critical that veterans receive their flu vaccines, as it can reduce their risk of developing serious complications, prevent hospitalizations, and death. And we wanted to improve our vaccinations for our veterans. This practice involves setting up a staffed mobile station equipped with a laptop, a refrigerated cart, and supplies to allow veterans to simply drive through when convenient to them, receive a flu injection without even getting out of their vehicle. This practice had a great impact. It improved vaccination rates. It provided access. It was convenient to our veterans. It provided veteran satisfaction and enhanced the veteran experience by offering a unique service that was not offered in the community and still is not today. It is very relevant during COVID-19 because it decreases their exposure compared to a walk-up clinic. And broad vaccination of our veterans and employees is so important to reduce the overall burden to our healthcare systems during COVID-19 and influenza. Next slide, please. As you can see from the bar graphs, the drive-through contributed to an increase in flu vaccinations compared to previous seasons during the month of October. One medical center showed an improvement of 11% in 2018, and then another improvement of 6% in 2019. Another clinic showed an improvement of 3% in 2018. We opened up the flu clinic to employees during 2019 season, and the flu vaccine rates also improved for employees from 30% during the 2018-19 season to about 43% during the 2019-2020 flu season. Next slide, please. To implement this practice is not hard. It required 2 staff members that worked about 25 hours each per week. It was easily operated, not hard to replicate, and no new hiring of staff is required. Space to set up is all you need, where cars can easily drive through and not cause any traffic congestion. You need a cover or tent for your staff and signs to direct traffic. We do recommend 1 temperature monitored refrigerated cart, about $3,200, stocked with flu vaccines, all the needed supplies, a laptop with Wi-Fi connectivity for charting and CPRS. This promising practice would be ideal for any medical facility or outpatient clinic or community-based outpatient. All you need is to have a covered carport, a drive-through area, or a large parking lot. This season alone, we have already had 5 additional facilities in our system start a drive-through vaccination clinic. So what are you waiting for? Bid on this practice, increase the safety for your veterans and the vaccination rates. Thank you.
Kelly, can you hear me?
I can hear you.
Right. What are people waiting for, right? Like, what's the problem?
That's
right. So look, I wanted to talk to you about a couple of risks. You know, there's been rumblings that COVID is going to be picking up again, and of course, we're right on the cusp of going in right into flu season. So, are you able to identify 1 or 2 risks that an implementing site could potentially face while implementing this practice, and what are the way you can mitigate those risks?
So there are, of course, always risks associated with any project. One of the risks associated with a drive-through clinic, of course, could be someone having a reaction to a vaccine. I have not, in my 20 years of practice, have not ever seen a reaction to a flu vaccine, but that's not to say it couldn't happen. So we take special precautions. If someone has never had a flu vaccine before, they cannot get one at our drive-through clinic. They have to go into the facility so they can be observed. There's always risk of someone having other health events during their time with us out there at the clinic. So we have a special protocol set up where we either call 911 or our emergency response team. And of course, there could always be a car accident or pedestrian accident that we have to be prepared for.
Understood. Thank you. And let's circle back to something that you mentioned in your presentation. Let's talk about the data a little bit. So, talk a little bit more about how collecting the data and how collecting that data actually impacts the practice.
Well, of course, because you want to be able to show that what your practice does has results. And so we have a team that we work with that collects the data. They collect it for how many flu vaccines are given for veterans and employees. And we keep that in a chart on an Excel spreadsheet so that we can make it readily available each year, each flu season.
Great. So for the leadership that is actually at your facility, who are key stakeholders in this, how are they being and how are they receptive to this practice so far?
They were very receptive. We actually started this in 2018 as an innovation grant, and they approved the flu cart for us to try them in 2 facilities. And then we continued it in 2019, and then of course, again this year.
Nice. And lastly, personally, how does this practice affect you? And what do you want to say to that before we close?
I really like it. It's so nice to hear our veterans as they drive by telling us this is the 3rd year in a row now. They're so glad we do this because it's convenient to them. And now with COVID-19, they don't have to go in. Even if they could go in, there's limited capacity that can go into our facilities. So now they don't have to worry about it and they can get vaccinated.
Thank you. I appreciate that.
Thank you.
Thank you, Kelly. Thank you, Devin. Next up, the practice that's presenting is EMS Clean Covers, presented by Robert Bankston of Vision 10 VA Northeast Ohio Healthcare System. Welcome to the Shark Tank, Robert.
Hello, all. You may be wondering what was removed from the camera. It was a small prototype of the EMS Clean plastic cover, a layer of protection used to fight infectious disease, dust, dirt, and debris from penetrating the patient's beds, gurneys, equipment, and clean linen after it's clean and prior to its next assignment. Next slide. The motivation was designed for my great-grandmother, Jessie Wright Bankston, who was diagnosed with lupus and a hospital-acquired infection in the 70s. The exact origin of the infection could not be traced to a specific incident, but however, at the young age of 8, I wondered if it was a direct result of her treatment or the cleanliness of her treatment space. I felt helpless watching her treatment and struggled over the years. I even promised I would become a doctor so I could take care of her. My grandmother passed away in 1978, thus made the dream of becoming a doctor seem pointless, although I promised to help her. There was no way I could save her life. I carried that guilt for years. Next slide. One day, while I was pulling up to the medical center, it dawned on me. I didn't need to become a doctor to save lives. EMS staff is instrumental in saving lives every day through cleaning and disinfecting, but my heart knew we could do more. The medical center has many patient beds, gurneys, medical equipment, and clean linen that should have an extra layer of protection while waiting use. Although they are clean, they can be exposed without an added layer of protection, which could result in contamination while in their designated areas or being transported throughout the medical center. Next slide. Regardless of the item of the EMS clean plastic cover provides, free of contaminants while in storage or en route to the destination, especially during COVID-19. It adds impact on it adds an amazing impact, internal and external, and for the qualitative measures and standpoint. It was deemed by best practice by Joint Commission, OIG, and EPS National Service Leadership. For starters, next slide. For starters, all you need is $240, 240 units at $1,280, and 0.2 FTE for a couple of weeks to put in your medical center. When it comes to saving the lives of veterans, medical center staff, and the value benefit of the EMS clean cover is immeasurable. I ask that you consider making this medical center daily cleaning routine. Our goal is to provide the best care to our nation's heroes with immediate impact. Sharks, you may wonder, why would I need the EMS clean plastic cover? A year ago, we did not need to wear a mask every day. This is a chance for you to be proactive instead of reactive. Thank you for your time and consideration, and have a great day.
Rob, how you doing?
I'm good. How are you?
I'm good. I'm good. Thank you for the presentation. So you kind of went a little fast over the cost of what's required. Can you just circle back to that and talk about that a little bit more about what's required for this implementation?
Yes. 250 units at $1,280.
All right, great. Thank you. Also, what are some of your stakeholders saying? Like, I'm sure you have to work with other people within the medical center who, in dealing with the equipment and everything else. How are they receiving this practice that you're doing? Is it positive? Is it negative? What are some of the things that's going on there?
So it's actually it's positive. With any prototype, you got to make adjustments.
Mm-hmm.
And we had OIG and Joint Commission come back to back last year, and there was a question about if a gurney was clean or dirty or whatever. Mm-hmm. And I ran and got the bag because we weren't using it on the gurneys initially. Mm-hmm. And once we put it on the gurney, Joint Commission and OIG was like, "This is best practice. You need to use this everywhere."
All right, great. You talked a lot about, the personal meaning to you, so I'm not going to really touch that. But I appreciate you bringing up the fact that, you was inspired by your grandmother to do something real important. I commend you on that. Let's talk about some of the data, though. Have you seen a change in any data in terms of you implementing this practice, and how can that be affected, or how can another facility who's trying to use it try to attain any data toward that?
So this is more of a qualitative instead of a quantitative. Mm-hmm. We're still studying the data, but to say that we have data to show that it has decreased infections, I can't say that, but I know it's an added layer of protection. So prior to being used, we know it's covered and it's not contaminated. So as far as the exact data, I can't give you that, but when patients or their families are walking into or visiting when they could before COVID-19, they were impressed because we went to the level of doing an extra layer of protection, such as COVID-19. All right. So it's more of a qualitative measure than a quantitative.
Awesome. Thank you. I appreciate that.
Thank you, Robert. Great job. Our next presenter is Epic Stress, eConsult protocoling to improve the quality of cardiac stress tests, presented by Nishant R. Shah of Vision One Providence VA Medical Center. Welcome to the Shark Tank, Nishant.
Thank you so much, Blake, and good afternoon to everyone, particularly the Sharks. Today, I'd like to give you 5 reasons the Sharks should invest in Epic Stress. Next slide, please. Reason number 1, the Sharks should invest in Epic Stress. It helps address a big problem. Published data show that up to 20%, that's 1 out of 5 cardiac stress tests performed within the VA may have been unnecessary. What does that mean? These tests performed have no or little to expected value in improving veterans' cardiovascular care, and they prolong wait times for veterans waiting for tests that are necessary. Next slide, please. Reason number 2, sharks should invest in Epic Stress. It is a simple solution to this big problem. The key innovation of Epic Stress is inclusion of an e-consult or an electronic consult with all outpatient cardiac stress test orders. This establishes a new avenue of care coordination between testing experts and clinicians that allows for real-time auditing and personalized feedback independent of the final test report. Next slide, please. Epic Stress e-consult responses are templated to include the test ordered and overall assessment of appropriateness and the rationale used for assessment. As with all e-consults within the VA, these responses must be generated within 48 hours and are used for both positive reinforcement and constructive criticism. Next slide, please. Reason number 3, the sharks should invest in Epic Stress. It has been proven to be effective. After 1 year of implementation at the Providence VA, Epic Stress was associated with a reduction in unnecessary stress tests from 8% to 2%, a reduction in veteran wait times for these tests from 26 to 21 days, and a decrease in wait times that were greater than 28 days from an overall percentage of 39% to just 20%. Next slide, please. Reason number 4, the sharks should invest in Epic Stress. It has a great return on investment. Implementation required only labor and totaled about $8,000. Soft savings from reduced quality achieved through reduction in unnecessary stress test orders was about $33,000. Therefore, the financial return on investment in Epic Stress was about $25,000. Now, importantly, the reduction in veteran wait times that I mentioned to you achieved are an important customer benefit that should be qualitatively added to the quantitative ROI that I just mentioned. Next slide, please. The 5th and final reason that you should invest in Epic Stress Sharks is that it can be yours for peanuts. For single site spread, I'm asking for less than 1/8 of FTE. Why so low? Because we in Providence have already done the hard work of building the CPRS e-consult architecture and the response templates. So all you really need to do is identify a local clinical champion who I will work with to ensure stakeholder buy-in, clinical utilization, and long-term satisfaction. For the VISN directors we have the Sharks, I'm asking for a little bit more FTE to establish a central Epic Stress hub that seamlessly coordinates with all of your medical centers. Next slide, please. I want to thank everyone on my team who contributed to this work, and my sincere thanks to the Sharks for their time and hopefully their investment.
Nishant, how you doing?
Very good. Thank you, Devin.
No problem, no problem. Thank you for the presentation. There was a lot of good information in there. I do want to circle back to the clinician's perspective though. As a clinician, could you kind of elaborate more on the clinician's experience using this practice?
Yeah, so before we implemented this practice at Providence, we did a lot of pre-implementation focus groups with the primary group that uses this, which are the primary care physicians. And they made it very clear to us that part of the reason that they ordered unnecessary stress tests was that it was very hard to keep up with all of the new guidelines about what was necessary and what wasn't necessary. So what we did with this innovation is really to make it simple for them. Part of this innovation is really providing real-time clinical decision support so that they know that they are ordering a test that is either necessary or unnecessary. And at least in the post-implementation focus groups that we've done, they seem to really enjoy that. The other thing that this innovation does is allow them to actually put in a consult without a test order, which wasn't possible before, and to really ask the question, what is the right test in this veteran? And that's also something that they've said that they appreciate after this implementation.
So it sounds like one of the things that's truly going to define the success is communication, for one. Is that accurate to say? Great, thank you. Is there anything else in terms of you can give to the people who are bidding on this success factor? What do they need in terms for this to be successful?
All I really need is a clinical champion. Like I said, I've built the architecture for this in CPRS and that's done. I just need somebody on the ground there to help me understand the nuances at a particular facility. And then if anything needs to be changed, we'd be happy to modify this. But to be honest, it doesn't necessarily need to be modified and can be relatively easily implemented at a new facility.
Awesome. Thank you very much.
Thank you, Devin.
Great work, Nishant. Next up, we have increasing access to clinical research using an innovative mobile recruitment approach, the MORE concept, by Marcus Johnson of Vision 6 Durham VA Medical Center. Welcome to the Shark Tank, Marcus.
Thank you, Blake, and thank you to all the other members of the VHA Innovation Ecosystem team, our audience, our sharks, and most importantly, our veterans. Thank you for your service. As Blake mentioned, my name is Marcus Johnson. I'm here to present on our work to improve veteran access to clinical research. Next slide, please. We know both from the literature and anecdotally from our veterans that are in communication with our study teams that participation in clinical research is very challenging for them. Oftentimes they have to drive long distances to our hospitals, deal with traffic and parking, and then navigate our large facilities to identify and locate clinical research exam rooms and suites and meet with our study teams. These are all significant barriers to their participation in our studies. This is a critical issue for our healthcare system because findings from clinical research are used to improve healthcare delivery. Therefore, veteran participation in clinical trials directly contributes to improving healthcare delivery in the VA and in the medical community at large. Many of our VA facilities are actually participating in various clinical trials that are underway to develop vaccines and treatments for COVID-19. And I think that's a great example of the importance and relevance of clinical trials in today's healthcare landscape. So to tackle this issue, we developed the MORE approach, which uses mobile recruitment units as a tool to improve veteran access to clinical research. The concept really revolves around us bringing research to veterans as opposed to having them come to us to participate in research. Next slide, please. So Sharks, I'm sure that your next question is, what is a mobile recruitment unit? So the image on the right shows a MORE unit that's set up and ready for a study visit. These units include items such as a laptop, a privacy screen, a phlebotomy stand, a portable printer with scanning and copying functionality, an insulated cooler for biospecimen transport, and several other smaller items. And to the left, you'll see that the MORE unit can be easily packed up. It's very similar to luggage, and it's ready to be transported to its next stop as needed. Next slide, please. So for our pilot, we looked at the impact of our MORE units on the MVP study, which is a high volume observational cohort study and mega biobank in the VA. We utilized these units at 7 different VA hospitals, and we're actually able to deploy these units to 27 additional locations at those sites, primarily our community-based outpatient clinics and community events, to really give veterans more options for where they might access clinical research. So we looked at the impact on MVP enrollment over an 18-month period and found that enrollment over that time period increased by an average of almost 39% across those 7 sites. Next slide, please. So our strategy is relatively inexpensive, with the cost of all the MORE unit components totaling about $2,000. No additional FTE is required for implementing the strategy. These units are simply a tool that clinical research study teams at your facilities can use to improve veteran access to our studies. Next slide, please. Lastly, I'd like to thank my colleagues in the CSP Nodes program in the Office of Research and Development. Thank you to our Sharks for your time, and I'd be happy to answer any questions you have. Thank you.
Marcus, thank you. How are you doing today?
I'm doing great, Devin. How are you doing?
I'm good, man. I appreciate everything. So let me get this right. So easy to break down and transport, right?
Absolutely.
Cost is relatively low in terms of $2,000 per unit. Is that accurate?
That's accurate.
No FTE, right?
Exactly.
All right. And then you talked about the data. Let's dig in a little bit more to the data. Can you elaborate a little bit more on that? And is there any other data elements that can be taken from this implementation?
Right. So again, we looked at the impact of these units on enrollment in the MVP study over an 8-month period, 3 different time points, each 6 months in duration. So we looked at enrollment data over a 6-month period prior to deploying the MORE units. We looked at the enrollment data after deploying those units in the subsequent 6 months. And then we looked at the data in a post-intervention period just to figure out whether or not any impact that we saw during the intervention period, whether or not it could be sustained. And again, in total, we saw that enrollment increased by almost 39%.
Good deal. So, as a clinical researcher, I know that, everything is about the data and you're real analytical. And correct me if I'm wrong, but that's just what I'm gathering. But tell me why this is so meaningful to you from a personal perspective.
Well, from a personal perspective, it's meaningful to me, but really to us all as I mentioned there are a number of VA facilities that are participating in clinical research as it relates to COVID-19. And I think that we all have to chip in and do our parts to make research easy for our veterans to participate in if we want to address this pandemic in our healthcare system and the nation at large.
Great. And before we go, do you have any perspective from a veteran in terms of their experience that you want to discuss or talk about?
Right. So anecdotally, we hear that they appreciate not having to come to the main facilities. Again, they're often long distances from their homes. They appreciate not having to deal with parking at the hospitals. And so I think they really appreciate us coming to them at the CBOX and at the community events to meet them.
Awesome. Awesome. I appreciate that. Convenient, packable, inexpensive. It seems like the veteran like it. Good deal. Thank you.
I appreciate it. Thank you.
Thank you, Marcus. Great work. Before we dive into this next pitch, I do want to give a shout out to our audience, which is very excited and very active in the chat. Please keep adding comments. If you have questions for our finalists, go ahead and enter them in. If they don't answer them live in chat, we will relay those questions to the finalists and they can get back to you after the event. And now our next pitch is coming from Open House Initiative for Mental Health Service Connection, presented by Danielle DeMilo of Vision 22, Southern Arizona VA Healthcare System. Welcome to the Shark Tank, Danielle.
Thank you, and good afternoon. I'd like to begin with a quick story about a Vietnam veteran. Over his 30-year career, he had experienced severe trauma, and for 18 years after his retirement, he never sought mental health treatment. And he's not alone. I have come to know many veterans under similar circumstances, and I'm sure you have too. Next slide. In 2017, when we started this initiative, over 6,000 veterans committed suicide, an average of 17 per day. And it's only getting worse, with a current daily average of 20 veterans. Sadly, those who are not engaged in VA healthcare are at even greater risk. Over 65% of veterans who commit suicide are not taking advantage of VHA services. And here at the Savahix, thousands of unengaged veterans are at increased risk for suicide. Our Mental Health Open House Initiative is helping our veterans engage in mental health services at the VA to include reducing the stigma that's associated with mental health. Next slide. Our initiative outlines the holistic and wraparound services offered in mental health, as well as the whole health and home care programs. In addition to receiving presentations from subject matter experts, attendees have the opportunity to ask questions, gather resources, and meet with a mental health clinician and/or schedule an appointment within the mental health service. And in August of this year, we developed our very first virtual open house to adapt to the COVID-19 setting. And we're currently preparing for our second in November. Next slide. This mental health open house initiative is ideal for any sites that are offering outpatient mental health services. It's adaptable and flexible for both face-to-face and virtual settings. And it's scalable based on local needs and circumstances. And standard work is in place to assist. Next slide. The results speak for themselves. We have so far experienced a 10% increase in veteran engagement. Of those 10%, over 90% have decided to engage in mental health services, and nearly 33% have continued to actively participate. But it isn't just about the numbers. It's about the veterans. As for the veteran I mentioned earlier, he completed the inpatient PTSD program after months of individual and group psychotherapy, 18 years after he retired from the Army. No veteran should have to wait this long for needed care and services. We invite you to join us in making sure we leave no veteran behind. Thank you.
Danielle, excellent presentation. Thank you.
Thank you.
How you doing today? Good?
Pretty good, yes.
Good, good. Let's dig in a little bit, all right?
All right.
So let's talk about sustainment. So is this just at one facility, multiple facilities? Can you break that down a little bit?
We currently have this at this facility. We have also spread it to one of our community-based outpatient clinics in Yuma.
Mm-hmm.
We've also worked with Vision 22 to actually provide these services in our package actually of this program to all of Vision 22 because it's been identified as a best practice.
Mm-hmm.
And services and programs are voluntarily able to adopt this service. And we also presented over at Vision 5.
Mm-hmm.
This was about 6 months ago and sold our practice there too.
Awesome, good deal. So one of the things you had in your slide that I saw was something along the lines of FTEE neutral.
Neutral. Yes.
So can you explain that? And then is there a cost associated with this implementation?
So the FTE neutral means that we need no additional staff to provide this service. We recruit volunteers as an ancillary task because there's a lot of clinicians, particularly in mental health service, who are interested in process improvement and systems redesign. And so we recruit them, and then we meet weekly, and they provide some additional, have additional responsibilities, but it's nothing that requires an additional staff member. As far as the cost, there is cost when we've had the face-to-face open houses because we've offered food and door prizes, although we've gotten those through donations because our volunteer services allows for donations for veterans. And our virtual open house essentially is no cost because it's through WebEx and really just the cost of the staff and PowerPoint and all of the technology that we already have in place here at the VA.
All right, perfect. Thank you, Danielle.
Thank you very much. Have a good day.
All right, outstanding work, Danielle. We're going to move right along. Our next pitch is remote temperature monitoring and amputation prevention through telehealth, presented by Kyle Nordrum of Vision 10 Cincinnati VA Medical Center. Welcome to the Shark Tank, Kyle.
Thank you, Blake. Hello, everyone. Sharks, I'd like to start off with a question. Would you go to the next slide, please? Would you stand on a mat like this for 20 seconds a day if it could help save your feet from amputation? Think about that. I imagine most of you are thinking, yes, of course. And we're finding many veterans that agree with you. So let me share with you how we're preventing amputation in as little as 20 seconds a day with remote temperature monitoring. Next slide, please. There are a huge number of veterans at risk for amputation. About 25% of veterans have diabetes, and about 1/3 of them will have a diabetic foot problem throughout their lifetime. If we find one of these problems too late, it can lead to devastating consequences, as you can see pictured in the top right, which is a major amputation. It's worth noting that these problems disproportionately affect our minority veterans and those who don't have good transportation or the resources to make it in for routine follow-up care. You've already heard Secretary Wilkie talk about the astronomical cost of this problem as well, in excess of $3 billion annually. So it's a huge problem. What do we do about this? Our solution is to send our highest risk veterans a smart mat that they stand on for 20 seconds a day in their home. The mat takes thousands of temperature readings in their feet, sends this data off to the cloud, and our clinical team reviews it to catch problems early. The earlier we catch a diabetic foot problem, the easier it is to treat. We've seen extremely high compliance with this practice, and we've had multiple veterans rave about how easy it is to use. We're also seeing a huge return on our investment in prevention, with ROIs in the range of 3 to 4.5x. Next slide, please. In real-world clinical use at 2 different VAs, we saw complete elimination of all moderate to severe wounds with this practice. We also saw complete elimination of all major amputations and near elimination of all diabetic foot-related hospitalization. These numbers are really amazing, especially when you consider the cost of a new diabetic foot ulcer can be in excess of $40,000, and most of that cost comes from inpatient care. Excitingly, a study came out just this month that looked at resource utilization, and it estimated for every 100 veterans enrolled in this practice, the net savings could be as high as $1.2 million per year, 1.2 million a year. Next slide, please. The key thing to emphasize about this practice is how easy it is to implement. Your clinical staff will require some training, but there is no extra space or FTE requirements. This practice can help you level the playing field for veterans that can't easily follow up in clinic by bringing care to their homes. This is especially relevant during the current COVID-19 pandemic. No veteran should have to lose their limb to diabetes. We have the technology to virtually eliminate major amputation. So Sharks, if you'd like to help your veterans prevent limb loss and get a high return on your investment, then go bid for our practice. Thank you.
Kyle, thank you. How you doing?
Doing good, Devin. How are you?
I'm good, man. Thank you for the presentation. I appreciate it. I need you to educate me a little bit and forgive me for my naivete in advance. All right.
Sure.
So the foot pad itself, it goes to the home. Is that correct? Did I hear that correctly?
It does. It's used in the home. It has a built-in cell phone, so it works about everywhere. We joke that there's like one cave in West Virginia it doesn't work in, but everywhere else, you know, it's pretty functional.
So it's like an asynchronous SFT kind of application format. Is that correct?
Technology, you got it. So it lets it kind of capture that and review it and react to it.
All right, good deal, good deal. All right, so what are we talking about in terms of cost of the foot pad? Is there a cost associated with it? What are we talking about in terms of resources outside of the FTE that you mentioned?
Sure. So, key thing, no space, no FTE, but the mat itself does cost $3,500 roughly. But the key thing to think about is, with a return on investment of 3 to 4x, 3 to 4.5x, you're paying yourself back in the long run. We've heard that mentioned by our panelists multiple times. It's worth shifting towards a preventative model versus the sick care that Dean Kamen mentioned. And I think that's really important with a practice like this to focus on that preventative piece. So there is some upfront cost to save money and save limbs in the long run.
Understood. Thank you. So let's talk about some of the stakeholders that's involved. I heard wound care, so I'm wondering, have you talked to anybody in the Office of Nursing Service? What are some of the clinicians or stakeholders saying about this practice?
Sure. I think that's one of the things that I like most about this practice is there's not one discipline that owns it. I've talked to some sites where, PM&R kind of runs their amputation prevention program, other sites where podiatry is the main ones that run it, other places where, primary care might be the main one. And I could see multiple sites, making use of this regardless of their clinical team makeup. So.
All right. Awesome. I appreciate that. Thank you for the words. Great presentation. And you have a good day, man.
Thank you, Devin. You too.
All right.
Thank you, Kyle. Great work. Our next practice is called TeleCOVID, presented by Gauri Bahari of Vision 22 Phoenix VA Healthcare System. Welcome to the Shark Tank, Gauri.
Thank you. Hey, Sharks. Are you ready to hear how Phoenix had a cost avoidance of $500,000 within the first 2 months of the COVID pandemic? Next slide, please. We are all well aware of the crowded emergency rooms, increased overtime spending, overwhelmed call centers, PPE shortages, and staff shortages due to COVID-19 related illness or exposure. At the start of the pandemic, Phoenix needed an alternative for taking care of patients with symptoms concerning for COVID-19. Our solution, TeleCOVID. Next slide, please. Veterans can now call in to TeleCOVID and talk to a clinician in real time regarding their symptoms and concerns. Clinicians triage and manage patients by video or phone, then conduct follow-up visits over the next 7 to 10 days to ensure resolution of symptoms. In the first 2 months of going live, we saw 1,100 unique veterans. 95% were treated virtually. This led to a huge reduction in unnecessary ED volume during a national healthcare crisis. 50% of our patients lived over 30 minutes from their closest VA site. We were able to treat these veterans and avoid community care spending. 20% of our patients were rural. We were able to quickly see them from the comfort of their own homes. To date, we have seen over 6,000 unique veterans through over 10,000 encounters. in the 6 months since the pandemic started. Next slide, please. We have received a lot of positive feedback from veterans. During a poll, one veteran said, "I feel like they really cared about me." Another said, "They took care of me when I wasn't well enough to drive into town." One said, "I feel like you guys made a house call when I needed it the most." Veterans reported it took no more than 45 minutes when they called in to when they completed their COVID testing or had their filled prescription in hand. Mark Cuban was impressed. TeleCOVID took 2 weeks from concept to implementation. That must be some kind of VA record. TeleCOVID is FTE, space, and equipment neutral. You may be wondering, well, what if COVID is no longer an issue a year from now? Well, TeleCOVID is an adaptable program that can be modified as a seasonal clinic and can be rebranded to TeleFlu or TeleCold as needed. With a short implementation time, minimal resource requirements, and an adaptable structure, TeleCOVID is a veteran-centric win for any VA facility or network. Sharks, who's ready to make a splash with TeleCOVID?
Hey, thank you for the presentation. Great job. $500,000 cost avoidance is pretty major.
Yeah, at this point, we're probably close to millions.
That's awesome. That's awesome to hear. So let me ask you a question. Let's talk about some of the key elements for this practice. What are some of the key elements, and can you elaborate more on those elements that would really deem this truly as a success?
So a huge part of it was the multidisciplinary effort when the pandemic rolled out. Our stakeholders included leadership from our call center, from scheduling operations, nursing, telehealth, and the emergency department. That was definitely a major part of this. Another part of it is that we had help from our infectious disease department and helping to make sure that our team stayed up to date with COVID guidelines and testing protocols.
Awesome, awesome. Thank you. Let's talk a little bit more about the resource inputs. I know this is a telepractice, but are there any additional resource inputs that people should know about? Cost or FTE, anything else that is associated with this?
So for TeleCOVID, we used existing staff. So it's actually FTE neutral for our facility. We've been able to keep up with the surges in COVID demand and preparing in preparation for the current surge we're expecting soon. In terms of equipment, most of our staff is telework capable, which was needed as part of the transition during the pandemic. So we used existing staff for that part. And then in terms of space, we were space neutral because we used teleworking staff.
Awesome. That's awesome to hear. Last thing before we go, and with COVID, the uptick that's allegedly about to happen, right? What are some of the other risks that may be associated with this practice?
The ability to forecast staffing needs. This program is heavily based on having a clinician or somebody to answer the phone in real time to take care of these veterans. So if not appropriately staffed, you may need to create a way for patients to suspend a call so that they can have callbacks. So that would be the only modification if you're not able to provide adequate staffing for these surges.
Good deal. Thank you very much. Great job.
Thank you, Devin.
Thank you, Gori. Great work. Our next presentation is Telelactation Program, presented by Cody Giovanetti of Vision 9 Memphis VA Medical Center. Welcome to the Shark Tank, Cody. Hi, Cody, do you mind unmuting your mic, please?
Am I unmuted?
We've got you now. Thank you.
All right. Thank you, Blake. I'm excited and honored to be here on behalf of the Memphis VA. Next slide, please. I want you to close your eyes. Imagine a new mom who went to regular OB/GYN appointments, received good prenatal care, went to all the new parenting classes, read prenatal books, and talked with friends and family who had breastfed, as she had always known breastfeeding was the route she wanted to take to nurse her son. But shockingly, no lactation was given or offered during her time prenatally. She ended up delivering via an emergency C-section after 16 hours of labor. At that point, she was exhausted mentally and physically from the attempted labor and then an emergency surgery. Despite feeling prepared, breastfeeding was never a topic. So now her son is having trouble latching. She's suffering from low milk supply, exhaustion, and is vomiting from pain medication with no support in maintaining her breastfeeding goal at home. You might be surprised to know that this person was me. In fact, 3 out of 4 moms try to breastfeed but quit before 6 months. So as a result of my own personal struggles, I often wondered what we were doing to support our pregnant and lactating veterans. Unfortunately, lactation services are not routinely offered through the VA. And in fact, it's estimated that 80 to 85% of VAs are not providing lactation services. In 2016, I developed the Telehealth Lactation Program, which provides prenatal and postnatal lactation support and has reached more than 250 veterans thus far. In FY15, it showed that almost half of women veterans are childbearing age. Next slide, please. To date, the total cost savings from the clinic has been $450,000, and we've spread these services to 8 VAs. Since FY16, results from the clinic indicate that Memphis has a 90% initiation rate for breastfeeding. One lactating veteran reported, "I remember calling Cody with excitement about my baby latching because I felt like she was the only one that believed in me and encouraged me throughout my breastfeeding journey." Next slide, please. So here's the best part. In order to replicate these services, minimal supplies are needed. The main requirement is a 0.5 FTE who's willing to become a lactation consultant, and anyone who's a healthcare provider can become a lactation consultant. I've been told by one spread site, "You literally have it so we can all implement this program in a 2 weeks time frame." So Sharks, due to gaps in care, women veterans nationally are not likely receiving the support and encouragement they need to meet their breastfeeding goals. But if every VA provided these services, we could save $3 to $4 million. Yes, that's $3 to $4 million in just a year's time. So let's make an impact and start lactation services in your VA. Thank you.
Cody, how you doing?
Good, how are you?
I'm good. Let me just first say, shout out to you for giving the personal story, 1. 2, shout out to you for really putting an emphasis on women's health. So big up to you. I want to clap it up to you for that.
Thank you, I appreciate it. They're a deserving population.
Absolutely, no question about it. So let's talk about sustainment a little bit more. So, what are some of the elements that people at a new facility should know before they implement this, and what are some of the risks associated with that?
Sure, there's really no risk. The biggest thing is I give you initial steps, and it's a 1.5 day training with me. And then the person who is identified will have to get lactation certification. And from there out, I give you a toolkit that gives you step-to-step process for actually implementing and recreating what I've done in Memphis.
All right, is there any data that a person can glean to say, okay, this is why this practice has been so effectful and here's the impact, and this is why you should have it at your facility?
Sure. So we have no VA data. We don't have lactation services that are routinely offered. So really the impact is that we're making an impact. We're providing these services. We're supporting these veterans. 90% of our veterans are meeting their breastfeeding goals. And we do track them on a 3, 6, 9, 12-month basis to see how long they're breastfeeding. And for most of those, we are exceeding those rates compared to Tennessee's.
Great, thank you. I appreciate that. So you just knocking down all type of walls, huh? You just breaking.
Trying to.
All right, good deal. So last before we go, let me just ask you, talk more about the feedback that you received either from people at your facility, VISNs, other stakeholders who are helping you with this practice.
You know, I've only had great feedback. Everyone is very supportive and really, really wants to make an impact on the women population. And as we know, they're the largest growing, quickest, fastest growing population in the VA. So supporting them is just, fabulous. And, we're excited to spread or help anybody else that we can.
Awesome, Cody. Thank you.
Thank you.
Great job, Cody. We're moving right along. Love the chatter and the feedback in the chat. Also want to thank some of our Sharks. It looks like we've already seen some intentions to bid flying. You have, as a reminder, Sharks have until 10 a.m. Eastern tomorrow to submit their bids, but of course we love it when you come prepared. Shout out to David O'Meara, director out of Columbia, South Carolina. Our next presentation is Embedding Physical Therapy in PACT. presented by Amanda Simone of Vision 23 VA Midwest Healthcare Network. Welcome to the Shark Tank, Amanda.
Thank you. Excited to be here. Next slide, please. On behalf of Vision 23, thank you, Sharks, for this opportunity to share our practice of embedding physical therapy in primary care with you today. I ask each of you to consider for a moment something you love to do. Walking or hiking, playing with children or grandchildren, or perhaps you're a weekend warrior of some favorite sport. Now consider your personal healthcare experience at a time when you were injured and sought care to continue doing that thing you love to do. How does that compare to the current experience at your VA? Are your veterans satisfied with the service you're providing and choosing your VA? Next slide, please. If veteran satisfaction, wait time, specialty care provider referral volumes, or primary care provider workload are currently areas you would like to improve at your facility, we have a solution. By embedding physical therapists into PACT, we were able to reach and sustain the lowest average new PT patient wait time of any VISN, help reduce imaging and pain specialist referrals, and improve veterans function. Most meaningful, though, is our veteran satisfaction with this initiative. One of our many veteran testimonies here shows you the value to the veteran when the integration of physical therapy with primary care allowed him to receive same-day intervention to manage his pain without opioids and return to work the following day. Next slide, please. Vision 23 has the lowest average new patient PT wait time of any Vision, largely driven by the high volume of new patients we are able to serve same day in our primary care clinics. Have you ever walked down the hall at your VA, observed a veteran struggling to walk, and been concerned for their safety? At your VA, how long would that veteran need to wait to see a physical therapist? I think we can all agree that in those scenarios, what should and needs to happen is for the veteran to be able to go to a familiar clinic, see a physical therapist that same day, and ideally leave that clinic with the equipment they need without additional travel or delays within the medical center. This is just one of the values of embedding PT and PACT through this initiative. Next slide, please. The minimum requirements to do this really are low. A standard primary care exam room is sufficient, and there is no large expensive equipment to purchase. So depending on your situation, you may be able to achieve at least some of these results with careful realignment of existing resources. So really, why would you not take us up on our offer to assist? We have already figured out how to successfully embed PT and PACT in a broad range of hospital and outpatient clinic facilities across Vision 23, and 31 other VA locations report that they have already adopted this practice. So the better question is, will your site be next? Next slide, please. Thank you to everyone involved with making this project a success, and thank you to our Vision 23 leadership for continuous sponsorship of this and many other strategic initiatives. A special acknowledgement to Brandon Peterson, Doctor of Physical Therapy from the Sioux Falls VA, and Dr. Jerry Blow, a physician from the Central Iowa VA, who were the co-chairs of the initial work group for this implementation. Dr. Peterson is available to answer questions through the virtual chat, and I open the floor here for questions. Thank you.
Amanda, awesome. How you doing today?
Good, thanks. A little nervous.
No, you're good. You're good. We just talking. It's all good. So let me. I wrote a couple of notes. I want to make sure I got them down correctly. Okay. No large equipment. So when you say no large equipment, does that essentially mean no equipment at all? Because you talked about realigning existing resources also.
Yeah, so really the physical therapists who are embedded in primary care, they really just need an appropriate exam table. So typically that means a therapy exam table. However, if you're moving a physical therapist who's currently working out of a large gym space or something like that, they probably already have a treatment table that they're using that could probably be moved into a primary care exam space.
So that means, essentially no cost associated with this practice. Is that accurate?
It is possible to do this without additional cost.
All right, great. Is it in all of Vision 23?
It is. It's throughout Vision 23. We've embedded 7 of our 8 medical centers, and many of our CBOCs now have PT and PACT.
And just so I'm clear, you said 31 additional facilities actually are ready to get this queued up too also, right?
Yeah, we had an email go through our national PT listserv asking which other sites have already embedded PT and PACT, and that was the response.
Major move, Amanda, major move. Okay, so listen, let's talk about the veterans. You said that, you get a high volume of new patients within your Vision. What is some of the feedback that you are receiving from the veterans? Let's talk about that before we close up.
Yeah, they love it. You know, we are getting great reviews on V-Signals all the time. When we've done different Voice of the Veteran surveys associated with actually implementing this initiative and changing practice, they love the approach. They love that they're able to do it in their primary care clinic that they're familiar with. They love the scheduling process. They feel like it's easier. And so really great reviews from our veterans. They're very satisfied with this initiative.
Major moves, Amanda. Thank you very much. I appreciate it.
Thank you.
Thank you, Amanda. Outstanding work. Our next presentation is Virtual Integrated Primary Care Mental Health Integration Hub, presented by Kevin Kelly of VISN-4, Corporal Michael J. Crescens VA Medical Center in Philadelphia. Welcome to the Shark Tank, Kevin.
Thank you so much, Blake. And hello to Sharks and everyone watching. Access to behavioral health services can be challenging at smaller and rural CBOCs. So I ask, are your sites struggling with staffing and implementation of PCMHI? A negative impact on PAC-21 rates on your sale report? Lack of space and wait times for behavioral health? If so, we've created the solution for you, the Corporal Michael J. Crescens VA Medical Center in Philadelphia, in collaboration with VISN-4 leadership and our innovative partners at Wilmington VA Medical Center, created the Virtual Integrated PCMHI Hub. I'm sorry, next slide, please. Thank you. Deployable through a hub and spoke model, it consolidates staffing at the hub site and leverages existing telehealth technology like VA Video Connect for all PCMHI functions at the remote site. Recognized as a 2019 VISN-4 best practice, it promotes and provides rural veterans with equitable standards of behavioral health, including immediate same-day access, suicide prevention, early identification of behavioral health concerns, preventative care, and rapid initiation of care. Next slide, please. This model begins with the primary care provider initiating a virtual warm handoff by messaging the VIP Hub. VIP Hub coordinates with an identified team member at the remote site to begin an immediate 30-minute video appointment using an iPad. VIP assesses the problem, arranges follow-up, and provides brief feedback to the PCP about the plan. Those with mild to moderate symptoms can receive brief follow-up virtually with VIP, with continued collaboration with the PCP, while those with more severe symptoms are referred for specialty mental health at the remote site. Resources needed at the hub site include PCMHI staff with computer, camera, and phone, and at the remote site, an iPad, and occasional sharing of space for the 30-minute virtual warm handoff. Next slide, please. Since implementation at Wilmington, the VIP Hub has triaged 1,117 veteran referrals, successfully improved access, PCMHI referrals, and PAC-21 rates at every CBOC. For example, at the Northfield or Atlantic County CBOC, the percent of primary care patients who engaged in PCMHI services increased from 0.3% in July 2019 to 4.79% in September 2020. And we've improved the PAC-21 rate for the entire facility, helping Wilmington move from 9th out of 9 to 5th in VISN-4, and they are quickly catching the sites in 3rd and 4th places. Wilmington previously had very limited PCMHI at their CBOCs, but their willingness to try something new with the VIP Hub has empowered them to improve access for their veterans. Sharks, let's make this a success story for you and your veterans too. We would be thrilled to partner with you to improve access at your sites. Thank you.
Thank you, Kevin. How you doing?
I am doing well. How are you, Devin?
I'm good, man. Great job.
Thank you.
Hey, so let me ask you, I want to make sure that I understood this correctly in terms of the implementation practice, okay?
Okay.
So it's in Philly, it's in Philadelphia, and it's also in Wilmington, or no? Is it anywhere else?
Well, currently we use, so Vision4 leadership developed this great idea to be able to help an outreach to remote and rural veterans.
Good.
So
Okay.
we use Philadelphia as the hub site because of the strong infrastructure and expertise in PCMHI. And then we provide an outreach to other facilities. Currently, we're at all 5 CBOCs for Wilmington, VA, to be able to help rural veterans because they were struggling with staffing and implementation at PCMHI at those sites, which is a common problem.
And I'm glad that you mentioned some of the risk associated with that because I wanted to dive a little deeper. So can we talk about those risks associated with it, how you mitigated them, and talk about some of the other risks that you may have occurred during implementation?
Yeah, absolutely. Those are great questions. And these are important things to think about. We know that potential barriers can include at the remote site. Again, it's difficult to staff and implement PCMHI and I know from personal experience, at rural CBOCs. So a lack of experience or a previous or inadequate implementation of PCMHI at smaller clinics that may make providers wary of changing their referral process for mental health.
Okay.
And the host facility should be aware that this could be, a significant shift and change of referrals for mental health services. Of course, thinking about Wi-Fi, and because we use iPads for virtual warm handoffs, making sure that there's adequate Wi-Fi or being able to use CVT equipment.
Okay, great, great.
Go ahead, sorry, Devin.
No, keep going, you got it.
Also just thinking through the process of how we handle emergent referrals. So if there's a high-risk veteran at one of the rural CBOCs, thinking through that process of how we make sure the veteran is safe. And these are processes that our team has been working on for over 18 months. We have the processes polished. Our brilliant, innovative partners at Wilmington have helped us to do that as well.
Good deal, Kevin. I appreciate you and thank you.
Thank you.
All right, Kevin, great work. Thanks for that presentation. We're on the home stretch with our last 3 pitches. Now up, Vision 20, Centralized Lung Cancer Screening Program, presented by Christopher Slator of Vision 20 VA Portland Healthcare System. Welcome to the Shark Tank, Christopher.
Great, thanks, Blake. So as you mentioned, I'm Chris Slator. I'm a pulmonary physician at the VA Portland Healthcare System. And I've been involved in lung cancer screening as a researcher and as co-director of our centralized program for almost a decade now. And I'm super excited to tell you about our current proposal. Next slide, please. To start, I'd like to give you a brief background. You probably know that lung cancer is bad, but it's the leading cause of cancer deaths in the United States, including for veterans. And many veterans are more likely to get lung cancer compared to the general population because of higher rates of firsthand cigarette smoke exposure and occupational hazards in the military. Fortunately, lung cancer screening using annual low-dose CT scans lowers the risk of lung cancer mortality and is widely recommended, most important by the U.S. Preventive Services Task Force. Unfortunately, the VA, along with the US in general, has been slow to implement lung cancer screening, so many eligible veterans cannot access this service. But this information doesn't tell the whole story. For that, I want to read this quote from one of the veterans that has been served by our current program. He said, "I just want to thank the VA healthcare system. Recently was scheduled for lung cancer screening. To my surprise, they found it and removed the upper lobe of my right lung. I thank God this screening is being used to detect cancer early. This patient and this quote are the real reasons we've worked so hard to provide access to high quality lung cancer screening to veterans." Next slide, please. Based on recommendations from the US Preventive Services Task Force and VA's experience in the lung cancer screening pilot program, VA issued this 10N memo in 2017 to help clarify how lung cancer screening should be performed. Portland was one of the 8 sites in the pilot program, and we helped develop these core components of a high quality program based on evidence and our own collective experiences in the pilot. The 10N memo states that only facilities with these 8 components should engage in lung cancer screening. So we systematically work to build capacity in our area clinic by clinic so that now almost all 70,000 veterans cared for by the Portland VA are systematically assessed and offered lung cancer screening that follows the 10N criteria. Our mission has always been to provide a high quality service to veterans that minimizes the burden for primary care providers for coordinating their care. We have now achieved a hub and spoke program with a very high level of adherence and are starting to see a lung cancer stage shift, which is very strongly associated with reduced lung cancer mortality. Next slide, please. Now we want to expand our program to enable all veterans to have access to high quality lung cancer screening processes. We will centralize key portions of these processes such as shared decision-making and care coordination, while enabling veterans to obtain their CAT scan at their local facility. We'll utilize our radiology and pulmonary expertise to appropriately manage surveillance and follow-up procedures. The winning bidder will help support the nurse coordinator FTE necessary to run a high-quality program, with a small amount to support pulmonologists and radiologists as well. We will work hand in glove with the winning bidder to implement the necessary information technology tools to systematically identify patients and coordinate with their facility's existing resources for smoking cessation and lung cancer care. Overall, we aim to provide a high-quality service that reduces veterans' chances of dying from lung cancer while minimizing the burden on primary care providers to offer and maintain this service. If you want to make a dent in the huge burden of lung cancer care, please bid on us. So thank you for your time, and a huge thank you to the Portland team that has worked so hard to develop our program, our partners and collaborators across Vision 20, and everybody who's also committed to improving lung cancer care for veterans. And lastly, I want to acknowledge the hard work of the other Shark Tank competitors today. We're all working hard to improve care for veterans, and I'm super honored to be included with you. Thank you so much.
Hey, Chris, thank you for the presentation.
Thank you.
No problem, no problem. A couple of questions I have for you. Can we talk about data collecting for this practice? And can you talk about how it's an impact on the practice while you're implementing it?
Yeah, so that's part of what we do with integrating our nurse coordinator and our information technology tools, is keeping track of how many veterans we do the shared decision-making visit on, how many say yes to screening after being fully informed about it, how many then go on to the low-dose CAT scan, and then probably most importantly, how do we keep people coming back year after year? So this isn't just a one-time CAT scan. This is a CAT scan you have to get every single year while you're still eligible for screening. And so with some of that, we know that we've been able to now offer this service to the 70,000 veterans in our catchment area. We've been able to do about 7,000 CT scans. And most importantly, we were recently in a study that we showed that we had over 80% adherence to follow-up scans, which is both high within sort of VA programs, and it's actually super duper high compared to programs in the community. So we use those data to really help inform what we do, but also to make sure that we're, continually every single day doing a great job.
Good deal, good deal. Let's stay on the implementation wave right now for this practice. You talked about resources being an FTE, and then you said a small amount for some additional resources. Can you dive a little deeper into that and talk about what that means?
Yeah, so based on what we've been able to do here in Portland, we estimate that about for every 40,000 veterans that are in the catchment area for a facility, that equals about 1,000 that eventually say yes to getting lung cancer screening. And for that, we estimate that takes about a 1.0 FTE nurse time to coordinate care for those folks. And then we also include, I think, 0.2 FTE for a radiologist to help read all the CAT scans and supervise, and then 0.1 FTE for the pulmonologist that needs to help, coordinate services, work with the radiology team, and coordinate follow-up care.
Good deal. One more question before we wrap up. Is there any other costs associated with this practice, or that's just it that you just mentioned?
Those are it. We're trying to figure out how this is going to work with Cerner. So that's not really a cost, but it is something we have to consider as moving forward. So as you know, Vision 20 is going to be one of the first Cerner sites. Yeah. So one of the things we've committed to as a program is to work with that process so that we can continue this high quality level of service.
All right. So what you're saying is that's something to just keep an eye on as people bid on this, right?
Correct.
All right. Good deal. I appreciate that. Thank you, Chris. Have a good day,
Thank
man.
you.
All right.
Thank you so much, Chris and team there in Portland. Great work. Our next practice out of Vision 4 is Tele-Urgent Care, presented by Lori Conti of Vision 4 VA Healthcare.
Good afternoon, good evening. Thank you all for the opportunity to present Vision 4's Tele-Urgent Care program. Next slide, please. Community urgent care costs exceeded $1 million in Vision 4 this past year. And then there I was. I received a phone call from Dr. Timothy Burke, Vision 4's Chief Medical Officer, sharing his vision for a Vision-level tele-urgent care to increase access to care, reduce unnecessary urgent care community visits, reduce costs to the VA, and improve continuity of care for our veterans in this healthcare system. We established an integrated project team within a week and got right to work developing this program. Referrals to our program are generated by an RN triage in our VISN-4 Clinical Contact Center for on-demand warm handoff to VA Pittsburgh's emergency department providers. Next slide, please. U.S. Army veteran Mr. R. Moyer shared his experience. Mr. Moyer was so sick. His wife was at work with their only vehicle. He called the VA and agreed to a tele-urgent care appointment. He said, "We were done in 10 to 15 minutes. They ordered the meds I needed to a nearby pharmacy. I felt better in a couple of days. I never needed to travel to the VA nor spend the gas. I'm thankful this program exists." Next slide, please. We've been tracking successful utilization of this program for all veterans like Mr. Moyer, and we're proud to share that we've served 2,685 veterans in fiscal year 20. And when COVID-19 spiked in our region, we were ready. We've concluded that since January, 1,950 of those veterans had their issues resolved from tele-urgent care or through a down triage to their PAC team, saving the VA over $300,000 in community care payments to the urgent cares. Next slide, please. You too can create a successful VISN-level tele-urgent care. We partnered from the beginning with the National Emergency Medicine Team and Work Group to help create the National Implementation Guide. We have resources and strategies, all the tools you need to help you get started, and this all aligns with the Clinical Contact Center modernization effort. Mr. Moyer had his tele-urgent care appointment just before the COVID-19 outbreak, and he had this to say to fellow veterans. "Doing telehealth appointments just makes sense. It saves our healthcare system, saves on you, saves gas, and protects your health. It's just so much easier. So bid on tele-urgent care and save the system." Thank you.
Thank you, Lori. How are you doing today?
I'm doing well. How are you, Devin?
I'm good. Before we go into any questions, I just want to say shout out to you with the natural light coming into your house. Oh man, major.
Thank you. I'm blessed here.
No problem. I just wanted you to know that. So let me just let's get to the questions. Let's talk about user experience. Okay. You talked about the veteran experience, which is tremendous. Can we talk about the clinician experience, if you will? Could you elaborate on the clinician's experience using this practice?
Sure. We have such a great organization here in VISN-4. We have a clinical contact center full of nurses who are engaged to receive calls from veterans and get them directed to our emergency department team. Mm-hmm. We have an awesome group of physician assistant staff who primarily take the calls day by day. They have seen a tremendous impact that they can make by keeping these veterans at home, mm-hmm. out of busy emergency departments unnecessarily, and making a huge difference. They love seeing the data and seeing what an impact they can make.
Let's talk about that. You mentioned data. Let's talk about data. Can you dive a little deep in with the data that you collect and how it is impact? I know you mentioned
Sure.
it in the presentation. Let's talk about it a little bit more.
Yes, like when we started back in October, we had a very small portion of the program operating with just one provider, and we've grown to now using this team in the emergency department. So we're seeing how many visits, how many veterans we can take care of every day. Mm-hmm. And that number just keeps growing and growing. We started out as a Monday through Friday, 8 to 4:30 pilot. Mm-hmm. And I'm so excited to share that this Sunday, November 1st, we're expanding from 8 a.m. to 8 p.m., 365 days a year. So we're really looking forward to seeing what we can accomplish in evenings and on weekends and even handling holidays.
Great. And one more question before you wrap up. Can you go back and reiterate the resources that's needed for this practice in terms of FTE or finances?
Sure. So we did use existing teams within our clinical contact center as triage, and then using existing staff within the emergency department. Our network is supporting some of the funding for FTE. So we started with 2 and we're expanding to 4. But these staff are integrating throughout the emergency department and in tele-urgent care. So we're really working hard to utilize existing resources, but make sure that we've got that ample staffing as we grow and develop.
Awesome. Thank you, Lori. Good job.
Thank you.
Outstanding work, Lori. We thank you all for sticking with us. Now we're down to our last pitch of the 2020 VHA Shark Tank competition. Please welcome VA Voluntary Service Curbside Delivery, presented by Sue Curver of Vision 7 Ralph H. Johnson VA Medical Center in Charleston. Welcome to the Shark Tank, Sue.
Thanks so much, Blake. I just want to make sure that you can hear me before we get started.
We hear you loud and clear.
Fantastic. Good afternoon, Sharks. Before we start on the curbside delivery program voyage, I want to take a moment and ask you to consider one key question. What did you have for breakfast? Maybe it was something that you grabbed from the fridge on your way to work. Or maybe it was the same thing that you have every day. Or maybe you don't remember because so many things have happened in the last 8 hours and breakfast isn't the most important thing on your mind. Well, for a lot of our veterans, food is one of the only things on their minds. In fact, a considerable number of our veterans suffer from not having enough food, and that's why we launched the Curbside Delivery Program. Next slide, please. Nearly 2% of veterans who visit any VA medical center, including yours, experience food insecurity. And we know that COVID-19 has made this worse. In fact, many of our veterans have had to make tough choices, choosing to eat or choosing to pay bills, choosing to stay home or choosing to go to the grocery store and risk COVID exposure. So we launched Curbside Delivery as a way to minimize these hard choices. As a collaborative effort between voluntary service and multiple service lines, Curbside Delivery easily enhances other food programs that might already be in place. Our volunteer drivers drop off donated items directly to the veteran's doorstep through contactless delivery, which minimizes risk. And we include other critical need items and information about current happenings in their food bags. So, to keep the program sustainable, we do that through strong community partnerships, donations, and volunteer time. Our results prove that we're breaking down barriers to care that food insecurity and isolation can create. Next slide, please. In fact, since launching in April 2020, our program has met the needs of over 400 vulnerable veterans. And from a staffing perspective, we've used 12 volunteer drivers and coordinators and our current voluntary service specialists to make this program work. We've sourced almost $200,000 in donations, and we've captured almost 600 volunteer hours from VTN drivers who are already registered as VA volunteers. Next slide, please. We know that food insecurity is an issue for many of our veterans, which is why this program is perfect for you. All you need is a van, some volunteers, and a willingness to tackle food insecurity. But we want it to be easy, so we can offer you a step-by-step implementation guide to make this a win-win situation for your veterans and your sites. Sharks, take a bite out of the food insecurity issue, and let's bring curbside delivery to your facilities. Thank you.
Hey, Sue. Thank you. How you doing today?
I'm great, Devin. How are you?
I'm good. Shout out to Charleston. I started my career as a engineer in Charleston. So
great place.
Charleston's near and dear to me. Let me ask you a couple of questions in regards to additional stakeholders. You mentioned and talked about voluntary service, being a strong ally in this, obviously. But what about other stakeholders? Have you spoken to food and nutrition? What about engineering or the transportation department? How is what are some of the other stakeholders saying in terms of this implementation?
Devin, that's a great question. So I want to speak a little bit to both internal stakeholders and external stakeholders, because it takes both to make this program work. So,
all right, speak on it. Let's go.
Yeah, so from an internal perspective, we have worked very closely with nutrition and food service, with our social workers, with our mental health department, and of course with transportation.
Okay.
We gathered all of those stakeholders together, we had conversations, and then we put together a very quick training to make sure that everybody was on board and understood how this program works. So from that perspective, we have had great buy-in, and honestly, we couldn't do it without the help of those functions. From an external perspective, our community partners are really sort of the bread and butter that makes this work. Our volunteers are doing the driving. DAV gave us the vans. Our volunteer drivers really work in conjunction with DAV. The American Red Cross has been a strong proponent, and they've helped with the driving. Daughters of the American Revolution, the American Legion Auxiliary, and the American Legion have all given us very, very generous donations of food to keep the program, to keep it going. So without those internal and external stakeholders, we wouldn't be as successful.
Good deal. And correct me if I'm wrong, you said that this really kicked off in April of 2020, is that correct?
It did, and here's why. So voluntary service is really here to fill in the gaps, and that's what my incredible team does. When COVID first hit our area, we had this idea. We were looking around and kind of thinking, what's needed? And so we spoke to all of those internal service lines, and we said, hey, what's needed? And we realized that food was an issue, and people leaving their homes at a time when they were told to quarantine, that was an issue. And so my innovative team got together, we kind of talked a little bit, and this is what came out of that discussion.
Good deal. Before we go, what was some of the risk that you encountered when you was actually getting this off the ground?
So that's the beauty of this program. We have worked hard to minimize risk, and that really is why this exists. We're minimizing the risk of veterans who should not be going out and exposing and having potential exposure to COVID. Our volunteer drivers, they're already VA volunteers. So they've already gone through their background check. They're already in the system, and we gave them back their purpose. So instead of standing them down, we stood them right back up, just in a different way. So we have worked hard to minimize any kind of risk associated with this through PPE and the other practices that are already in place for our voluntary service programs.
Good deal. And all of that is broken down in your implementation toolkit, correct?
Our step-by-step implementation guide. And I think the greatest part about this is there really is no additional FTEs, and there's really no money because it's all through donated resources.
Good deal. Good deal. I appreciate you. Thank you very much.
Great. Thank you.
All right.
Thank you, Devin. That was fantastic. We've got a few great stories that came there. It was exciting. You really hammer-headed it home. You kind of circled the shark bait. You Mako'd it great. I don't know if there are any more shark things that we can talk about. I was actually thinking a little Buffett, fins to the left and fins to the right, but I might be dating myself with that. It was a fantastic experience. So day 2 has really been tremendous, and I'm hoping that Blake is going to come join me so we can talk a little bit about this and see what his experience. There it is. Man, that was a long way from the other side over there.
Who put these two sets 100 yards apart?
I don't know. We wanted to see if you were staying in shape. We did have that GeoFit that we wanted to work on that. So I haven't seen our blue friend, but I saw a lot of great shark innovations in there.
This was, to me, it was our best Shark Tank. As you can see, the finalists came presented. They brought so much passion. They communicated clearly. Appreciate the audience. You guys were great, very enthusiastic. And also want to give a shout out to our Q&A facilitator, Devin Harrison.
Devin, you did a great job. And as a fellow moderator, I got to tell you, you kept it light, you kept it bright, and a lot of great questions that you asked in there. So did you see anything that really got you going in this, Blake, in your presentations? I know you can't lean towards encouraging one or the other, but tell me what was kind of your feeling of the energy?
I think what highlights to me is just how much our employees empathize with the customer, how much they're anticipating the problems, how much they're trying to prevent these problems and create an entirely better experience, better outcome for the veteran. So we saw a lot of that today, and it made me super excited to be a VA employee.
Yeah, I'm always excited as a veteran when I look in and I see the faces of those employees and their excitement and their energy and the passion that they're bringing forward as they talked about the pride of what they've created at their VISN, the money savings, the time savings, the better veteran experience, preventing amputations, COVID, telehealth, I mean, all sorts of stuff here that just seem to really lead towards a better veteran experience overall.
They're an extremely talented group, and I think they tied it all together, like you said, both the clinical side, the veteran, and the cost and everything.
And how about your friend Mark Cuban sending in a big shout out? If you didn't think you were relevant, I thought that was a great note from Mark to let us know his reaction and that he was supporting us.
He's always been a great supporter. I think he loves how this whole concept is translated to the healthcare environment and veterans, and so we really appreciated him, obviously, joining us today.
That's fabulous. Yeah. Blake, you did a great job, and thank you for including us in that.
Absolutely. Last bit, get in your votes, audience, by 10 p.m. Polling will close at 10. Sharks, you have until 10 a.m. to place your bids, and we'll announce the 10 Shark Tank winners tomorrow afternoon at 4:45 p.m. as part of the IEX Awards ceremony. I'll give it back to you.
All right, thank you very much, Blake. So very, very big shout out to all of those who put this together, to the Atlas team that's made this possible, to the folks here at the Press Club today. It was just an absolutely wonderful experience. To the production crew, to the camera team, thank you so much. And to our veterans who have reached out to make this possible. The chatter was great. I'm still missing the blue shark. Now here's the question. Special kudos if you can figure out who was the shark, who was wearing the suit. Go onto the chat site and let us know. Tomorrow is also jam-packed. We have a whole bunch more of innovation. We have the Innovators Network, the Diffusion Summit. We have the celebration of 12 promising practices of Cohort 5, the Diffusion of Excellence, the virtual exhibit hall, and overall we have the awards that are going to be presented later on tomorrow afternoon. I want to thank you. My name is Joe Grace, Navy captain, your captain for this event, and a veteran. Most of all, for all of you at the VA. Thank you for your service. Thank you for your time. We look forward to seeing you tomorrow at noon. Go Navy.